that's the forward button, is it? Anyone tell? Yeah, good. Mark, thank you for that introduction. I guess one of the only attributes I've got these days is I've been around for a long time. Getting old isn't great, but it's better than the alternative. So my brief is to touch on some of the important aspects of diabetes and its management, but particularly with reference to a historical view of what's been going on in the Garvan Institute's diabetes research program over the last 50 years. Can everybody hear me all right? Good. So that's the Garvan Institute when I walked into it in 1967, and I walked into it more or less on the same day as Professor Ted Cragen, who's been my research colleague for over 50 years. As you can see, the big building behind is the nurses' home, not more of the Garvan Institute. So the Garvan Institute then would just about fit into the atrium of the present institute today. And I guess at the time I started, there were about 5 or 6 people in the building actually doing research. So there are now well over 500, so things have changed. That 1967 was 45 years after Banting and Best discovered insulin in Toronto in Canada. And that was one of the great landmark findings, not just of diabetes research, but of medical research of all time. Prior to that, Sydney Hospital and various other hospitals had wards where they put people with terminal cancer or with type 1 diabetes because it was a sentence of death. And then in 1922, insulin came and things were transformed, at least for type 1 diabetes. However, things weren't all that good, and we needed better ways, particularly of treating type 2 diabetes. And the first bit of research I got involved with here at the Garvan was to do with what's called the cretin effect. When people without diabetes or people with early type 2 diabetes eat a meal, they produce insulin from the pancreas to deal with the meal, but the amount of insulin they produce is not just to do with the rise in blood sugar, it's to do with gut hormones that stimulate the pancreas to release extra insulin. And we were amongst the first people to recognise the importance of that. And it's a big effect. So if you look at what the amount of insulin would be if a non-diabetic person eats a meal, if it just depended on the blood sugar level, and you look at what actually happens with the effect of the gut hormones, it's a 300% effect. So it's a very big effect, and we thought then that if we could work that out and isolate the particular gut hormones that did it, this might lead to new therapy. So this was one of the early studies we did. We gave glucose intravenously, and on the left you can see the blood sugar levels change, and then on the right you can see the insulin response. So the blue is without any supplement, and the red is when we gave what was then an impure preparation of gut hormones, and we didn't quite know what it was that was doing it, but something amongst those gut hormones was greatly magnifying the insulin response. Now, we and others exemplified the importance of that. We then moved off into other areas of research, which was a great pity because that was where the money was. But it took about 30 years before the particular gut hormones that did this were isolated and before treatment became available, and there are a group of drugs that stop the destruction of these hormones and therefore enhance their effect, and there are also a group of compounds, Biata being the most commonly used one in Australia, which are an analogue, a facsimile of these hormones, which are injectables which augment the insulin response. So it was a fairly important piece of work. Now, the Garvan then moved on to looking at various aspects of insulin delivery at a time when people were starting to fiddle with the insulin molecule to change its rate of absorption and so on. So there were quicker acting insulins and slower acting insulins and so on. But by this time I'd gone overseas for a while and to Melbourne for a few years, and while I wasn't here, sadly for me, the most important piece of research ever done by the diabetes group at the Garvan Institute was done, and that was low-dose infusion of insulin for diabetic ketoacidosis, and it was generated by Ted Cragen's study of the interaction between blood glucose and insulin, and this particular study was done by Drs. Kidson, Casey, Cragen and Lazarus. Prior to this, when people with type 1 diabetes got seriously ill with this way out of control diabetes, there was about a 12% mortality rate, and large amounts of insulin were injected under the skin with very variable results. Sometimes it seemed to do very little, sometimes it actually did too much, and it was quite a difficult proposition, whereas what this study showed was if insulin was infused intravenously at a slow, even rate, the response of blood glucose, and more important, the response of the blood potassium level was even and predictable, and the whole treatment was much safer. And over the next few years, the mortality rate from diabetic ketoacidosis fell from 12% to 3%. So this was really a landmark piece of research from here. As I said, one unfortunately I had nothing to do with it. Then I came back from Melbourne to the Institute, and with Professor Lazarus we managed to get the hospital to set up for us a diabetes centre. You might have noticed as you came in, the diabetes centre of the hospital is now in the Garvan Institute on the level you came in, but at that time we set it up in a terrace house a little bit up the road, and this was aimed to give people better treatment for their diabetes without hospitalising them, but also as a key aspect of our coordination between research and clinical management. Now, the hospital bought this nice little terrace house and painted it up and put a big number on it so everyone would know where to go, and this was a more sleazy area in those days. The local neighbourhood thought it was a new brothel being set up. So we got interested in various aspects of insulin delivery, and we started the first patient on a subcutaneous infusion pump in Australia, which is now commonly used in type 1 diabetes. We also, or TED, developed a bedside device for helping to control diabetic patients in hospital, and this is a much younger me and Ted demonstrating this to Barry Jones, who you might remember as a famous Labor politician and quiz kid. So now, while we were doing those things to do with insulin delivery and so on, unfortunately the massive epidemic in Australia was progressing. These were the AusDiab studies, and showing you how between 1980 and 2010 there was a massive increase in the prevalence of diabetes in Australia, and that was mainly to do, not entirely, but mainly to do with type 2 diabetes and to do with adiposity, fat distribution and insulin resistance. So our interest really shifted very much into trying to analyse what were the different factors in that. And one of the things we recognised quite early was that all fat isn't bad. In fact, some fat's quite good. Having fat on your bum mightn't get you into Vogue magazine, but it's metabolically quite healthy. But fat in your tummy is very bad. So when we did studies to determine how insulin-resistant people were, because insulin resistance is a major factor in type 2 diabetes, and we compared the degree of insulin resistance to the amount of fat in various parts of the body, you can see that an R squared of 0.8 means there's a fantastic correlation between fat in your tummy and how insulin resistant you were. But if you look at fat in the whole trunk, that's still pretty strongly correlated, whereas fat on the upper arms and shoulders is not hardly correlated at all, and fat around your legs and your buttocks is not correlated, and in fact if you do the right adjustments it's arguable that it's quite good for you. So it had previously been shown that, and I'm sure you're familiar with this, that there's a very strong genetic element in how fat you are. But what we showed for the first time, and there were two studies, one done by David Carey and one by Kathy Samaras, both in McGarvin, that if you looked at identical twins and non-identical twins, and you looked at how much abdominal fat they had, you can see for the monozygotic or identical twins, the amount of abdominal fat was almost identical in the two twins. If you looked at non-identical twins, dizygotic twins, you can see there's not the same amount at all. What this showed is that there's a very strong genetic determinant of how much fat you have in your tummy. So we already knew there's a very strong genetic determinant of how fat you are overall. This showed there's also a very strong genetic determinant, which is different genes that determine where you put your fat. So if you've got the genes to put it on your buttocks, that's great. If you've got your genes to put it in your tummy, that's not so good at all. We, amongst others, were also involved in looking at the fat cell, the adipocyte, as a source of good and bad hormones. I won't bother you with the bad hormones at the moment, and this is a bit out of date, but fat produces some bad hormones, but it also improves very important good hormones, two of which are leptin and adiponectin. Now, about this time, Professor David Cooper and Andrew Carr walked into my office and said, look, we're treating people with AIDS with these new drugs, this is in the 90s, and we're seeing that some of them are getting diabetes and they're looking funny, will you help us sort it out? And in fact, what they were talking about was this. This is one of a patient with AIDS on the early, in retrospect fairly nasty, HIV drugs, and he's lost a lot of fat around his face and his shoulders, but he's kept the fat in his tummy. So what has become evident with these studies and others, if you've got a condition that causes you to lose your good fat, it's just about as bad as being too fat overall. And this was what we were describing here was the lipodystrophy syndrome. If you're a medical researcher and you publish a paper and you get 100 citations, people quote it 100 times, you feel pretty good. If you quote it gets quoted 200 or 300 times, you feel even better. If it gets quoted 500 times, people refer to it as a citation classic. The 3 papers that we published on this now have something like 6,000 citations. So it really created quite a lot of interest. Now, I haven't got time to go into all the detail of our studies on diet and exercise, but with Arthur Jenkins, Professor Leslie Campbell, and more recently with Jerry Greenfield, who you're about to hear from, we did quite a lot of studies on diet and exercise, and at the time, in the 80s, the world recommendation for a diabetic diet was high complex carbohydrate. We were amongst the first to show that's absolutely wrong, and that low GI foods, low carbohydrate, high protein, high fibre is likely to be the best recipe. But above all else, in type 2 diabetes, it's calorie restriction that, that is of the utmost importance. Low saturated fat has some importance in regard to cardiovascular disease, which of course is a extra risk in type 2 diabetes. And one of the things that I've struggled with over the years is some dietitians have continued to preach that if you're someone with diabetes, you have to have a between-meal snack. Now that used to be necessary in type 1 diabetes with the old insulin. It's arguably not necessary now with the very quick-acting insulins anyway, but it's certainly not necessary or even desirable in people with type 2 diabetes who are not taking insulin. So no need in most people to be having between-meal snacks, and of course getting your calories down is easier if you don't have them. You'll hear a bit more from Martin Witham shortly about exercise and maybe harnessing some of the molecules in exercise for treatment, but exercise is a very important modality of treatment in type 2 diabetes. In fact, one of the studies we did many years ago shocked me, although I shouldn't have been shocked because it was known in the literature, showed that if you simply cut calories in overweight people, they'll lose nearly as much muscle as they'll lose fat. Whereas if you restrict calories and they exercise, they'll lose more fat and less muscle. So exercise is quite important in that way. We used to think that the exercise had to be aerobic, walking, jogging, dancing and so on, but it's now quite clear that resistance exercise using weights or springs is just as good. And it should be at least 30 minutes a day, and we suggest a level of about 50% VO2 max. Now, if you don't know what that means, it means you're exercising at a level that you could carry on a conversation, but you'd have to puff between sentences. So that's the sort of thing. But you'll hear more about that from the others. Now, it's all very well to say diet and exercise is important, go out and do it. It's a real struggle. And for people who are very overweight, it's sometimes an impossible struggle. So, and again, I think you'll hear more about this from Catherine Tonks later, but one of the modalities that's come in recent years and can be an extremely important aspect of treatment in people who are very overweight and who struggle to lose it is bariatric surgery. And there are various types of bariatric surgery, surgery on the stomach, there are bands, there are taking part of the stomach away, there are reconnections of the upper intestine, but whichever one you do, you get a lot of weight loss. This is a percent change in weight, so you can see whichever modality you use, you're losing something like a quarter of total body weight. And that, unlike diets where people do well for 6 months or 12 months but then struggle to keep it off, it does stay off pretty well, and this is out to 15 years. So I'm not telling you all to run out and have bariatric surgery, and I would like to think in the future we'll have much better treatment to help people control weight without going through under the knife, but nevertheless this has been a terribly important advance. Thank you for listening to someone a bit past his use by date.